All right, let's pull on our detective hats for this one. We're about to investigate a particularly tricky culprit, gastric cancer. Now, this disease is a master of disguise, often hiding in plain sight. So our mission today is to uncover its playbook, understand the tools we use to unmask it, and really see why catching it early is the single most important part of the case.
So, our investigation kicks off with a really surprising clue. We tend to think of gastric cancer as a disease that affects older people, right? But check this out. About 1 in every 10 cases shows up in patients who are under 45. This isn't just a fluke. It's a whole different beast we call early-onset gastric cancer, or EOGC.
And this leads us right to the heart of the mystery. Why is it that in younger people, this cancer is often so much more aggressive? It frequently presents at a really advanced stage. And what's fascinating is that it doesn't seem to be as connected to the usual suspect we blame, the H. pylori bacterium. This tells us we might be dealing with a totally different kind of problem, something baked into the tumor itself.
To understand how this tumor operates, our first real clue comes from the biopsy. So, under the microscope, gastric cancer pretty much follows one of two paths. You've got the intestinal type, which is kind of like a weed that grows in one spot, usually sprouting from long-term inflammation. But then there's the diffuse type, and this one's way sneakier. It's more like grass sending out these invisible runners everywhere, with individual cells just infiltrating the stomach wall. And knowing which one you're up against, it's absolutely crucial for predicting how it's going to spread.
Okay, so here's where our investigation hits a huge snag. Our go-to surveillance tool, the trusty CT scan, has a major blind spot. Now, it's great for spotting big, bulky tumors, no question, but it often completely misses tiny, widespread cancer deposits that are just sprinkled across the lining of the abdomen, the peritoneum. We call this peritoneal disease, and missing it is like missing the key clue that changes the entire direction of the case.
So, when should our alarm bells really start going off? Well, the guidelines give us a handy checklist of high-risk features to look for. Is the tumor digging deep into the stomach wall? Has it already spread to nearby lymph nodes? And, most importantly, is it that sneaky diffuse type we were just talking about? If you see these signs, you have to operate under the assumption that the scan is not telling you the whole story.
So how do we get around that CT scan's blind spot? Well, we have to go look for ourselves. And for that, we bring in a specialized tool, the staging laparoscopy. It's a minimally invasive surgery where we put a camera right into the abdomen. This lets us see with our own 2 eyes if there are any of those hidden cancer deposits. We also do something called a peritoneal washing. We basically rinse the cavity with fluid, collect it, and send it off to the lab to look for any microscopic fugitives.
And this is the moment of truth. That simple peritoneal washing can become the most powerful clue in the entire investigation. Because if the lab finds even a few microscopic cancer cells in that fluid, what we call positive cytology, or CY1, the case is cracked. That patient is immediately restaged to stage 4 metastatic disease. And just like that, the entire goal of treatment shifts because a curative surgery is no longer on the table.
Now, we've been talking about how these diffuse-type tumors behave, but why do they happen in the first place, especially in young people? Well, sometimes the answer isn't in the environment, but in the person's own genetic blueprint. There's this powerful inherited syndrome called Hereditary Diffuse Gastric Cancer, or HDGC. It's linked to a mutation in a gene called CDH1. Think of it like a ghost in the machine, passed down silently from one generation to the next.
So what does it actually mean for a person to carry this one genetic mutation? The lifetime risk of developing gastric cancer is just staggering. It's up to 80%. This isn't just a risk factor. For many people, it's a near certainty, and that demands a really profound and proactive response.
And just look at how serious the official recommendation is. The guidelines couldn't be clearer. For someone with a confirmed CDH1 mutation, the standard of care is to remove their entire stomach as a preventative measure, often as soon as they're in their 20s. It is a radical, life-altering surgery, all they get ahead of a cancer that's almost guaranteed to show up.
So you can see how all this detective work, the biopsies, the scans, the laparoscopy, the genetics, it all leads to this massive fork in the road. On one path, if the cancer is localized, our goal is curative. We're going for a big surgery to get it all out. But on the other path, if we found that it has spread, our goal becomes palliative. That means controlling symptoms and using systemic therapy to improve and prolong life as much as possible.
Sometimes the cancer gets a little careless, and it just gives itself away without us needing all these high-tech tools. There are these classic telltale physical signs of incurable disease, named after the doctors who first described them. Finding something like a Virchow's node in the neck or a Sister Mary Joseph nodule at the belly button, well, that's like finding a signed confession. There are definitive clues that the cancer has already spread far and wide.
So why does all this staging matter so much? Let's just look at what it means for survival. If we catch the cancer at stage 1, the outlook is actually pretty optimistic. The 5-year survival rate is around 65%.
But watch what happens as that window for a cure starts to close. Just one step up, at stage 2, that survival rate gets nearly cut in half. It drops all the way down to about 35%.
By the time you get to stage 3, the prognosis is even tougher. Survival drops again, now down to about 25%. You can just see this steep, unforgiving cliff, and it's why every single step of our investigation is so incredibly critical.
And for stage 4, that's the stage confirmed by that positive laparoscopy or one of those classic physical signs. The 5-year survival rate is tragically low. We're talking less than 5%. This is the stark reality that our investigation uncovers, and it's the reason why getting the stage right is literally everything.
Okay, let's wrap up our investigation with the absolute key clinical takeaways. First, and this is a big one, always be suspicious of gastric cancer in a young patient, even if they just have vague GI symptoms. Next, please, distrust imaging alone when you see those high-risk features. You have to dig deeper, and that's where laparoscopy comes in. It is the essential tool for getting the stage right. And while you're in there, remember that cytology is the final verdict. A positive result means metastatic disease, period. And finally, especially with those diffuse cancers in young people, always think about that genetic ghost in the machine.
And this brings us to one last thought to chew on. We're getting so much better at identifying these genetic risks, like HDGC. It really makes you wonder, right? Will we get to a point where our understanding of genetics is so precise that proactive prevention, maybe through lifestyle changes or targeted therapies, could one day make a radical procedure like removing a stomach a thing of the past? It's a hopeful thought to end on.